Eczema, dermatitis, toxicoderma. Eczema, dermatitis, toxicoderma. Пишет, да, пишет. Etiology and pathogenesis eczema. It is necessary to comprehend the eczema is polyetiological disease with complex pathogenesis where the main role is played by allergic factors affected the organism with change reactivity of the central and vegetative nervous systems. To autoallergic phenomenon is of certain significance, which is due to presence of fungal infection, visceral and endocrinopathy, immune condition. Eczema starts with the formation of monovalent sensitization, increased sensitivity towards and certain allergen, which afterwards might transfer into polyvalent sensitization. Pathogenic types of eczema: true eczema, microbial eczema, nummular eczema, varicose eczema, post-traumatic eczema, seborrheic eczema, infantile eczema. True eczema, microbial eczema, nummular eczema, varicose eczema, post-traumatic eczema, seborrheic eczema, infantile eczema. Classification of dermatitis: simple dermatitis, physical, mechanical, chemical, biological, allergic dermatitis. Physical, mechanical, chemical, biological, allergic dermatitis. Eczema. Used as clinical descriptive term, it describes a process that is clearly superficial in form and that early is erythematous, papulovesicular, oozing and crusting, and later red-purple, scaly, lichenificate and possibly pigmented. Epithelial disruption and non-sharp margination are its characteristic. True eczema. The main role in pathogenesis is played by a polyvalent sensitization and pronounced neurogenic disturbances. Clinical features: disseminated, symmetric and blunt borders of the lesions, intense itching. Primary lesion is a punctulate microvesicles, serous wells, crust with small foci, fine laminar desquamation. True eczema. The main role is pathogenesis is played by a polyvalent sensitization and pronounced neurogenic disturbances. Clinical features: disseminate, symmetric and blunt borders of the lesions, intense itching. Primary lesions is a punctulate microvesicles, serous wells, crust with small foci, fine laminar desquamation. First appear eczema, against the background of which microvesicles, the size up to of a pinhead, papules, mostly exudative, and pustules are formed. Eczema vesiculosum, papulovesiculosum, papulosum, and pustulosum. The microvesicles in the center of the focus rupture, the ceroid exudate seeps onto the skin surface and produced oozing areas with a macerated and scaly horny layer, eczema meditans. Careful examination of the focus will reveal numerous points, erosion from which small drops of serous exudate emerge serous wells. The macrovesicle in the center of the focus rupture, the serous exudative seeps onto the skin surface and produced oozing areas with a macerated and scaly corneal layer, eczema medidans. Careful examination of the focus will reveal numerous point erosion from which small drops of serous exudates emerge serous well. Stage morphology of lesion symptom: acute, vesicles, blister, intense red, intense itch, stinging, burning. Acute process: vesicles, blisters, intense red, intense itch, stinging, burning. Stage morphology of lesion symptoms: subacute process: scale, red, fissuring, patched appearance, scalded appearance, slight to moderate itch, stinging, burning. Red, scale, fissuring, patched appearance, scalded appearance, slight to moderate itch, stinging, burning. Chronic process: thickened skin, lichenificate, excoriation, thickened skin or lichenization, lichenificate, excoriation, fissuring, moderate to intense itch. Thickened skin, lichenificate, excoriation, fissuring, moderate to intense itch. Dyshidrotic eczema. Dyshidrotic eczema is a deep vesicular skin reaction involving the fingers, the intradigital space, and the feet. Dyshidrotic eczema is a deep vesicular skin reaction involving the finger, the intradigital space, and the feet. The vesicles have a characteristic morphological appearance as that of sago grains. The condition is rare in young age group and more common in adults. The condition is rare in young age group and more common in adult. Pruritus is common. Sometimes lesions can be painful or it may be asymptomatic. Scratching of vesicles lead to weeping and crusting. Microorganisms of their product that clear when the organism and eradicated may cause microbial eczema. This should be distinguished from infected eczema, in which eczema is complicated by secondary bacterial or viral infection of the broken skin. The skin becomes sensitive to bacterial product or chemicals present in the exudate. Infection eczematous dermatitis is considered as an example of autosensitization. The mechanism by which microorganisms can cause eczema is not understood. Bacterial antigens can promote a cytotoxic reaction in the skin. The skin becomes sensitized to bacterial product of chemical present in the exudates. Infection eczematous dermatitis is considered as an example of autosensitization. The mechanism by which microorganisms can cause eczema is not understood. Bacterial antigens can promote a cytotoxic reaction in the skin. The distinction between infective and infected eczema is difficult. Infected eczema shows erythema with exudation and crusting. The exudation may be profuse with crusting or slight with accumulation of layers or somewhat greasy, moist scale below the surface is rare and red. Infected eczema shows erythema with exudation and crusting. The exudation may be profuse with crusting or slight with the accumulation of layers of somewhat greasy, moist scale below the surface is red and red. The margin is characteristically sharply defined. There may be small pustules and fissura in the advancing age. Infective eczema usually presents as an area of advancing erythema, sometimes with microvesicles. It is seen predominantly around discharge wounds of ulcer or most skin lesions of other types. Infective eczema usually presents as an area of advancing erythema, sometimes with microvesicles. It is seen predominantly around discharge wounds of ulcer or moist skin lesions of other types. Infective dermatitis is relatively common in patients with venous leg ulcers, but care must be taken to distinguish it from contact dermatitis due to topical preparation. Infective dermatitis is relatively common in patients with venous leg ulcers, but care must be taken to distinguish it from contact dermatitis due to topical preparation. Varicose vein microbial eczema. Acute inflammation is characterized by a red, superficial, itchy plaque with weeping and crusting on the lower limbs, especially the medial sides of lower legs, ankles, and calves. Acute inflammation is characterized by a red, superficial, itchy plaque with weeping and crusting of the lower limbs, especially the medial sides of lower legs, ankles, and calves. This is due to a combination of eczematous change and cellulitis, a vesicular eruption on the palms, trunk, extremities sometimes accompanies this acute inflammation. In subacute and chronic stage, an increased hydrostatic pressure lead to extravasation of red blood cells from the leg veins. Disintegration of these red blood cells lead to hemosiderin deposition. Disintegration of these red blood cells lead to hemosiderin deposition. The skin looks dry, scaly, hyperpigmented, and accompanied with white atrophic change. The skin looks dry, scaly, hyperpigmented, and accompanied with white atrophic change, atrophy blanche. Ulceration is common in the late stage as its serious consequence. The skin looks dry, scaly, hyperpigmented and accompanied with white atrophic change, atrophy blanch. Ulceration is common in the late stage and is serious consequence. Nummuliform microbial eczema. Nummular dermatitis is a chronic eczematous lesions that is caused by different known and unknown factors. The condition may be preceded by atopic dermatitis. The lesions may appear as a separate entity and as annular, coin-like or discoid lesions on the extensor surface of the extremities, trunk and the buttock. Nummular eczema, discoid eczema, is characterized by circular or oval plaques of eczema with a clearly demarcated margin. The typical lesions are coin-shaped, 1 to 5 cm in diameter each place. They are commonly distributed on the extremities and can become generalized. Acute lesions may be vesicular. Chronic lesions may become scaly and confluent. Seborrheic dermatitis. Seborrheic dermatitis is characterized by a distinct morphology, red, sharp-like, marginate lesions covered with greasy-looking scales. Red, sharp-like, marginate lesions covered with greasy-looking scales, and distinct distribution, scar, face, and upper trunk, which are areas rich in sebaceous glands. Seborrheic dermatitis is characterized by a distinct morphology, red, sharp-like, marginate lesions covered with greasy-looking scales, and distinct distribution, scar, face, and upper trunk, which are areas rich in sebaceous glands. Face, localized face, medial sides of the eyebrows, glabella, nasolabial folds are predilected size. Blepharitis is a feature. Medial sides of the eyebrows, glabella, nasolabial folds, and predilected sides. Blepharitis is a feature. Seborrheic dermatitis, scar. Dandruff is usually the earliest manifestations. In chronic cases, there may be hair loss which is reversible when the inflammation is controlled. Ears are a common sites of the involvement. Dandruff is usually the earliest manifestation. In chronic cases, there may be hair loss, which is reversible when the inflammation is controlled or are a common sites of involvement. Seborrheic dermatitis trunk. Petaloid forms is commoner than the pityriaziform. Follicular papules with grassy scale that may become confluent and commonly found over the sternum and interscapular region. Marwan. Закрыть.
Мне как-то не разрешить, откуда знаем, что за программа. Не разрешить.
Или закрыть просто.
Не разрешить просто.
И это удалить. Sternum and intrascapular region. Intrascapular region. Infantile seborrheic dermatitis. The eruption in infantile frequently first appear between the 3rd and 8th weeks of life. It may start in the napkin area, the face and scar, and occasionally on the trunk outside the napkin area. The rash comprise well-defined areas of erythema and scaling with tiny vesicles. Papular and lichenificant lesions are not seen. Typically, the infant is well and not irritable. The prognosis is usually good. Most are complicated cases clear in 3 to 4 weeks. Irritant dermatitis. Irritant dermatitis can affect virtually anyone depending on the person's skin barrier function and the potency and duration of the irritant stimulus. Irritant dermatitis range from mild erythema to hemorrhagic bulla and necrosis after several episodes of irritation, and person is often at risk for allergic sensitization. Mechanical irritation accounts for the majority of unpleasant reaction due to plant exposure. Irritant dermatitis can affect virtually anyone depending on the person's skin barrier function and the potency and duration in the irritant stimulus. Irritant dermatitis range from mild erythema to hemorrhagic bulla and necrosis. After several episodes of irritation, a person is often at risk for allergic sensitization. Mechanical irritation accounts for the majority of unpleasant reaction due to plant exposure. Diagnostic features. The affected sites characteristically conform to history of specific contact to a susceptible contact. Some non-exposed areas are also susceptible to irritant contact dermatitis, body folds, and flexor areas due to a combination of friction and direct contact with sweat of urine. Once exposure on the irritants ceases, improvement starts to occur. Once exposure to irritant ceases, improvement starts to occur. Strong irritant contact dermatitis can occur after a single brief exposure. The latent period is short. Examples are acid and alkaline burns, thermal burns and frost bits. The offending irritant is usually obvious. Weak irritant contact dermatitis develops after multiple exposures. Latent period is long. Weak irritant contact dermatitis develops after multiple exposures. Latent period is long. Management. The offending irritant should be identified and removed. Soap and detergents should appropriately be minimized. Cool water is less detrimental than hot water. Advice on the use of protective barriers whilst at work. Gloves, protective clothes should be strictly followed by the patient. Restoration of the lipid layer can be accomplished by frequent application of emollients. In case of maceration, wet clothing should be changed frequently, non-porous clothing to be avoided. Inflammatory elements can be controlled with topical steroids. The characteristic distribution of the lesions can often give a clue to a particular allergen. Removal of suspected allergen leads to resolution of the dermatitis. A positive patch test to a suspected offending contact supports the clinical diagnosis. Both allergic contact dermatitis and irritant contact dermatitis bear similar clinical signs. In acute cases, weeping and crusting will be present, while in chronic cases, scaling and fissuring are the dominant findings. Sometimes allergic contact dermatitis differs from irritant contact dermatitis in that erythema and edema may be more prominent and pruritus more troublesome in the former. Allergic dermatitis. Acute allergic contact dermatitis is characterized by pruritus papules and vesicles on an erythematous base. Like conificate, pruritus plaques may manifest chronic allergic contact dermatitis. Occasionally, allergic contact dermatitis may affect the entire intermovement. Erythroderma, exfoliative dermatitis. The initial site of dermatitis often provides the best clue regarding the potential cause of allergic contact dermatitis. Differential sign between simple dermatitis, allergic dermatitis, eczema. Sensitization, simple dermatitis absent, allergic dermatitis monovalent, eczema polyvalent. Time of development of inflammation under the effect of irritant. Time of development of inflammation under the effect of irritant. Simple dermatitis immediate, allergic dermatitis for a few hours to 1 day. Eczema, few days and more. Localization. Simple dermatitis, one the place of the effect of irritant, allergic dermatitis on the place of effect of irritants, and outside is boundary. One the place of effect of irritant and outside its boundary. Eczema on different place of skin. Eczema on different place of the skin. Character of focus. Simple dermatitis, diffused. Allergic dermatitis, diffused with secondary elements. Eczema, combination of diffused and distributed elements. Eczema, combination of diffused and distributed elements. Polymorphism. Simple dermatitis, not expressed. Allergic dermatitis, weakly expressed. Eczema expressed. Itching. Simple dermatitis, absent, usually burning and pain. Allergic dermatitis, moderate. Eczema, intense. Progress. Simple dermatitis, not long. Allergic dermatitis, longer. Eczema, long. Relapses. Simple dermatitis, absent. Allergic dermatitis, rare. Eczema, frequent. The first step in the identification and removal of the contactant, a detailed history and a careful examination is usually sufficient. Patch testing is indicated for cases in which inflammation persists despite evidence and appropriate topical therapy. For acute inflammation with blister and intense erythema, good yet compress. They should be used for 15 to 30 minutes, several times a day, until blister, and severe itching is controlled. Prednisolone in dosage of around 30-40 mg a day in divided doses is used for extensive inflammation. Topical steroids for reduction of local inflammation. Neurodermatitis definition. Lichenification denotes a cutaneous response to repeat rubbing or scratching. It is characterized clinically by a thickened appearance of the skin with accentuation of the surface markings so that the affected skin surface resembles three-back. Lichen simplex is a circumscribed area of lichenification resulting from repeat rubbing and scratching occurring on the some predilect sites. This term is used when there is known predisposing skin disorders. Neurodermatitis. Women are more common affected than men. Pruritus is the predominant symptom. It is often out of proportion to the extent of the objective change. During the early stage, the skin is reddened and slightly edematous, and the normal marking and exaggerate. The redness and edema subsides, and the central area becomes scaly and thickened and sometimes pigmented. Almost any sites are affected, but the commonest sites are those that are conveniently reached. The usual sites are the nape of the neck, the lower legs, and arms. The sides of neck, the scalp, the upper thighs, the vulva, pubis of scrotum, and the extensor forearms. A search for a causation should be made before the lichenification is considered to be primary. Then a careful physiological history should be taken and the patient gives some assistance in reducing her tension. Topical steroids in the treatment of choice, sometimes with occlusion, to enhance absorption and prevent user scratching. Intralesional triamcinolone is useful for circumscribe chronic lesions. Topical antibiotic may be prescribed if secondary infection is present. Atopic dermatitis. The etiology is unknown and the pathogenetic mechanism are speculative. However, a number of clinical, pathological, and immunological abnormalities are frequently observed in these patients. Elevated immunoglobulin E occur in about 80% of atopic dermatitis patients and are directed against a wide variety of antigen-like pollens, molds, foods, house dust, meats, and bacterial antigens. A high immunoglobulin A level is not a unique feature of atopic dermatitis but appears to correlate with the clinical severity and falls with remission. Atopic dermatitis clinical features: pruritus, dry skin, xerosis, eczematous lesions, prurigo, lichenification, denim organ fold, hand and feet involvement. Pruritus, dry skin, eczematous lesions, prurigo, lichenification, denim organ fold, hand and feet involvement. Infantile phase. Lesions first appear on the cheek, forehead, and scalp, but may occur on the trunk, neck, hands, and feet. Eczema with oozing and crust are more typical. Nocturnal restless, irritability, and crying are prominent. When the child begins to crawl, the exposed area, especially the extensor aspect of knees, are affected. Childhood phase. At about 8 months, the eczematous lesions tend to be replaced by lichenification. Prurigo papules occur and are very itchy. Elbow and knee flexures, wrist and arms and neck are commonly involved. The neck may show streaking, reticulate repigmentation, dirty neck. Hands may be dry and lichenified. Sole involvement may mimic juvenile plantar dermatosis. The face is least frequently affected. Problems with schooling may occur. A young adult face. Predominant features are pruritus, lichenification, prurigo papules, scratch marks and crusting. Lesions occur mostly on the face, neck, flexure, and upper trunk. Localized patch of eczema around the nipple or formation of the lips can occur. Physiological Difficulties occur in some. Adult phase. Adult resolves spontaneously is most patient after age of 20. Majorities of the patient, however, still have sensitive, unstable skin and higher tendency to develop dermatitis. Full-blown atopic dermatitis occurs is only a small percentage of patients throughout adulthood. Psoriasis. Psoriasis is a chronic inflammatory disease of unknown cause. It is considered to be due to T lymphocytes mediated disease of abnormal keratinocytes proliferation in genetic predisposed subject. Is a chronic inflammatory disease of unknown cause. It is now considered to be due to T lymphocytes mediated disease of the abnormal keratinocyte proliferation in genetic predisposed subject. Etiopathogenesis. Genetic factors. Multifactorial inheritance mechanism and etiologies without any genetic component have not yet been ruled out through many families appear to exhibit autosomal dominant patterns of inheritance with decreased penetrance. Multifactorial inheritance mechanism and etiologies without any genetic component have not yet been ruled out through many families appear to exhibit autosomal dominant patterns of inheritance with discrete penetrance. Environmental factors. Infection and a number of physical agents, e.g. HIV infection, alcoholism, smoking, ultraviolet light, all can affect the cause, duration, and clinical appearance of plaque psoriasis. Infection and number of physical agents, e.g. HIV infection, alcoholism, smoking, ultraviolet light, all can affect the cause, duration, and clinical appearance of plaque psoriasis. Trauma. All types of trauma have been associated with the development of plaque psoriasis, e.g. physical, chemical, electrical, surgical, infective, and inflammatory types of injury. All types of trauma have been associated with the development of plaque psoriasis, e.g. physical, chemical, electrical, surgical, infective, and inflammatory types of injury. Sunlight. Most patients generally consider sunlight to be beneficial for their psoriasis. Most patients generally consider sunlight to be beneficial for their psoriasis. Infection. Pharyngeal streptococcal infection have been shown to produce a clinically distinctive disease flare known as guttate psoriasis. HIV. An increase in psoriasis activity has been observed in patients who are or become infected with HIV. Drugs. A number of medications have been shown to cause an exacerbation of psoriasis. Psychogenic emotional. Many patients report an increase in the psoriasis severity with physiological stress. Smoking. An increased risk of chronic plaque psoriasis exists in cigarette smokers. An increased risk of chronic plaque psoriasis exists in cigarette smokers. Alcohol. Alcohol is considered a risk factor for psoriasis, particularly in young to mid-aged males. Endocrine disorders. Psoriasis severity has been known to fluctuate with hormonal change. Psoriasis severity has been known to fluctuate with hormonal change. Season form of psoriasis. According to the climatic and meteorological factors, winter, intensification in the cold period of the year, summer and mixed forms are differentiated. Winter type of psoriasis is found more often than other forms. Winter forms, summer, autumn, spring, and mixed forms. Stage. In the progress of clinical development, 3 stages on inflammatory process are distinguished: progressive, hospital, and regressive. For the progressive stage, characteristic feature are intensive itching, development of new papules, peripheral growth of old papules, presence of the inflammatory crown around the papula, Koebner phenomenon. At the hospital stage, fresh lesions do not develop. The peripheral crown are absent. Koebner phenomenon is not seen. At the regressive stage, the lesions are compressed, get pale, the desquamation decreases or stops, depigmentation of the crown take place around the papula, pseudo-atrophic Voronov's crown, and resolution of the lesions. Non-pustular psoriasis. Chronic plaque type, acute guttate, inverse flexural, erythrodermic or erythroderma psoriatic regional, palms and soles, nails, and sebopsoriasis. Pustular psoriasis. Generalized pustular psoriasis, von Zumbusch. Localized pustular psoriasis, palms and soles. It's very resistant forms for treatment psoriasis. Localized pustular psoriasis of palm and soles. Psoriasis with arthropathy. Oligoarticular asymmetrical arthritis. Symmetrical involvement small joints of fingers. Likes rheumatoid arthritis. Classical distal arthropathy involving classical distal arthropathy involving distal interphalangeal joints, destructive arthritis, mutilans, and psoriatic spondyloarthropathy, mutilans and psoriatic spondyloarthropathy, which is similar to ankylosing spondylitis, Clinical features psoriasis. Commonest form of psoriasis is the chronic plaque type, which usually presents as brightly erythematous scaly plaques as the predisposed areas. Plaque types which usually present as brightly erythematous scale plaques as the predisposed areas, the extensor aspect, the type of elbows, knees, sacral area, the scar. Extensor aspects, the tip of elbows, knees, sacral area, the scar. They may be associated with no symptoms to moderate pruritus or to moderate itch. Excessive dandruff and scaling from the lesional area may be an early complaint. Excessive dandruff and scaling from the lesional area may be early complaint. Koebner phenomenon. Three intensive phenomena occur in psoriasis. Any form of trauma may result in psoriasis appearing in the traumatized areas, which is known as Koebner phenomenon or isomorphic response. Any form of trauma may result in psoriasis appearing in the traumatized areas, which is known as Koebner phenomenon or isomorphic response. Koebner phenomenon or isomorphic response. Voronov phenomenon. Well circumscribed margins, psoriatic plaques are well defined and have sharply demarcated boundaries. Psoriatic plaques is well defined and have sharply demarcated boundaries. Psoriatic plaques occasionally appear to be immediately encircled by a paler peripheral zone referred to as the yellow ring of Voronov. Well circumscribed margins, psoriatic plaques as well defined and have sharply demarcated boundaries. Psoriatic plaques occasionally appear to be immediately encircled by a paler peripheral zone referred to as the yellow ring of Voronov. Tried Auschwitz or Auschwitz phenomenon. Psoriatic triad consists of three consequent phenomena appearing after scratching psoriatic papilla. Psoriatic triad consists of three consequent phenomena appearing after scratch psoriatic papilla. First, intense desquamation with silver white scaling remaining stearine macula phenomenon. Second, shiny surface after the removal of scales, shiny surface after the removal of scales, terminal psoriatic film phenomenon, terminal psoriatic film phenomenon. And third, drop bleeding infuses scratching, phenomenon of drip bleeding, phenomenon of drip bleeding, phenomenon of drip bleeding. Chronic plague type, chronic plague type. Plague psoriasis, the most common type of the disease, is characterized by raised, thickened patch of red skin covered with silvery white scales, characterized by raised, thickened patch of red skin covered with silvery white scales, well circumscribed margin, psoriatic plaque are well defined and have sharply demarcated boundaries. Symmetry. Psoriatic plaques tend to be symmetrically distributed over the body. Acute guttate. Psoriasis is characterized by small drop-like lesions. The small guttate maculopapular scaly lesions still have the characteristic feature of psoriasis, and hence there will be no diagnostic problem. The small guttate maculopapular scaly lesions still have the characteristic feature of psoriasis, and hence there will be no diagnostic problem. Inverse flexor psoriasis may lack the prominent silvery scaling because the flexor areas affected usually appear as brightly erythematous, homogeneous, well-defined and sharply demarcated plaque or patch with or without superinfection with candida. Homogeneous, well-defined and sharply demarcated plaque or patch with or without superinfection with candida. Erythrodermic psoriasis or psoriasis erythrodermia is characterized by intense redness and swelling on large part of the skin surface. It results from unfavorable external factors, irritating treatment, and can be noted in 1–3% of patients with psoriasis, in whom there is usually a decrease in immunological indicators and high allergic reactivity. Due to this, the whole skin takes of bright red color with severe edema. In different places, edema and infiltration are unequally marked. High desquamation, falling out of hair, enlargement of lymph nodes, destruction of nails, and suppurative paronychia are observed. Regional nails. Nail involvement is commonly seen in all types of psoriasis, which can affect the nail matrix and nail bed, leading to pitting, discoloration, subunguinal hyperkeratosis, onycholysis, splinter hemorrhage. Circular area of discoloration of nail bed resembling an oil drop underneath the nail oil drop sign is most characteristic of psoriatic nail. Seborrheic psoriasis. Many doctors may not consider the existence of this condition, seborrheic or seborrheic psoriasis. Very often we can encounter condition in which both psoriatic and seborrheic eczema features are present. We considered this a separate entity because it is not rare. Genetically constituted psoriatics can develop seborrheic eczema lesions at the scalp, eyebrows, and regions of earth with characteristic morphology of psoriasis. Pustula psoriasis. General pustula psoriasis can present in psoriatic-prone patient who is given systemic steroid for other condition and upon sudden withdrawal of the steroid, generalized pustula psoriasis will be prescribed for the first time. Occasionally, it develops from the unstable nummular psoriasis of acrodermatitis continue after inappropriate irritant therapy of withdrawal of extensive topical steroid. Localized pustular psoriasis of palms and soles usually presents as asymmetrical monomorphic eruption of small sterile pustular eruption of hands and feet. They painful rather than pruritic, very often brownish thick wall pustules are found. They are resistant to treatment and will be quite disabling. Another form of local pustular psoriasis is asymmetrical involvement affecting distant phalanx with nail destruction. Psoriatic arthropathy. Radiological examination of the affected joints may confirm the psoriatic arthropathy. The following fingers are characteristic sign of psoriatic arthropathy: destructive distal interphalangeal arthropathy with bony ankylosis of the interphalangeal joints, abnormally wide joint space, and well-demarcated edges, bony surface. Bony proliferation of distal phalanx in grade 2, resorption of tufts of distal phalanx of hands and feet. Investigation. The typical histopathology of psoriasis. Regular elongation of the red ridge with thickening in the lower portion, elongation and edema of the papilla, thinning of the subpapillary portion of the stratum malpighiae with the occasional presence of a very small spongiform pustules, the absence of granular layer, parakeratosis, and presence of Monroe microabscess. Differential diagnosis. Psoriasis and secondary syphilis. Psoriasis and secondary syphilis. Subjective feeling. Each of different intensity. Syphilis, absent subjective feelings. Lesions, psoriasis papulas, syphilis polymorphism, except roseola pustula. Color of the papula, psoriasis pink, syphilis copper red. Character of desquamation. psoriasis silver white scales, first in the centers and then of the whole papilla, syphilis on the periphery of the papilla bead scala. Predominant localization, psoriasis extends the surface of the limbs, hairy part of head, syphilis absent, infection of mucus, psoriasis usually absent, syphilis frequent, tendency towards fusion, psoriasis characteristic, syphilis absent, psoriatic phenomenon characteristic, and syphilis absent. Serological test, psoriasis negative, syphilis highly positive, syphilis highly positive. Lichen rubber planus, etiology and pathogenesis. There is an opinion that the disease is infectional by nature as it is successfully treated with antibodies and viruses are revealed inside the cells. Other specialists consider it to be neurogenic genesis and think that stress condition may be reason of the disease as hypnotism and reflex segment therapy is successful in some patients, situation of the lesions along the course of nerves. Attention is paid to the hormonal deviation and metabolic upset in patients with plain red lesions. Family hereditary predisposition is observed. Lichen planus may cause a small number of skin lesions or less, often affect a wide area of the skin and mucous membranes. In 85% of cases is cleared from skin surface within 80 months, but it may persist longer, especially when affecting the mouth or genitals. Mucous membranes. Classification. Classical lichen planus, oral lichen planus of nails, atypical lichen planus, hypertrophic or verrucous form, atrophic and sclerotic form, pemphigoid or bullous form, lichen rubber moniliformis, acuminate perifollicular form, annular form, lichen planus pigmentosa, actinic lichen planus. Actinic lichen planus. Clinical lichen planus is characterized by shiny, flat-topped, firm papules varying from pinpoint size guttate to larger than a centimeter. They are a purple color and often are crossed by fine white lines called Bickham stria. They may be close together, of widespread or grow in lines, linear lichen planus or rings, annular lichen planus. Linear lichen planus can be the result of scratching or injuring the skin. Also sometimes there are no symptoms. It is often very itchy. Hyperpigmentation. New lesions may appear while other unclearing. As the lichen planus papules clear, they are often replaced by areas of the grayish brown discoloration, especially in dark-skinned people. This is called post-inflammatory hyperpigmentation and can persist for months. Oral lichen planus. The mouth is involved in 50% of cases and is often the only affected area. The usual areas affected at the inside of the cheeks and the sides of the tongue, but the gums and lips may also be involved. May also be involved. Oral lichen planus. The most common feature are painless white streaks in lack of tone-like pattern, painful and persistent ulcers, erosive lichen planus, diffuse redness and peeling of the gums, desquamating gingivitis. In some cases, oral lichen planus affecting the gums is due to contact, allergy to mercury in amalgam fillings of newborn teeth. The cause can be confirmed by patch testing. In these patients, the lichen planus may resolve of replacing the filling with composite material. If the lichen planus is not due to mercury allergy, removing amalgam fillings is very unlikely to result in cure. If the lichen planus is not due to mercury allergy, removing amalgam fillings is very unlikely to result in cure. Lichen planus of nail. Lichen planus affects one or more nails in 10% of cases, sometimes without involving the skin surface. If all nails are abnormal and no hair else is affected, it is called 20 nail dystrophy. The nail plate tends to thin and may become grooved and ridged. The nail may darken, thicken up or lift off the nail bed or onycholysis. Sometimes the cuticle is destroyed and forms a scar. The nail may shed, stop grooving altogether, and rarely completely disappear. Sometimes the cuticle is destroyed and forms a scar. The nail may be shed, stop growing altogether, and rarely completely disappear. Atrophic and sclerotic form. Atrophic or sclerotic change may occur after the papules and plaques resolve. Because of its light color, the bleached-like cicatricial atrophy is called lichen albus. It may be localized on the neck, wrist, chest, and abdomen. Microfocal atrophic alopecia may develop on the scar in case of pseudopelade, which is accompanied with symptoms of follicular keratosis on the extensor surface on the lips, little lesions symptom. Microfocal atrophic alopecia may develop on the scar in case of pseudopelade, which is accompanied with symptoms of follicular keratosis on the extensor surface of the limbs, lid lasers syndrome. Hypertrophic form. Lichen planus may affect any area, but it most often seen on the front, on the wrist, lower back, and ankles. On the palms and soles, the papilla are firm and yellow, very thick scaly patch, and particularly itchy, and are most likely to areas around the ankles, hypertrophic lichen planus. Very thick scaly patch are particularly itchy and are most likely to arise around the ankles, hypertrophic lichen planus. Lichen rubber moniliformis, acuminate perifollicular form, is characterized by large cherry stone in size, lesions treated like the beads of necklace. The pustule are dome-like, rounded, wax-like, keloid-like, and are arranged like beads, which creates the impression of narrow keloid bands. In some cases, the lesion resembles a necklace without keloid-like strands. Follicular lichen planus, also known as lichen perifollicularitis. Result is tiny red spiny papules around a cluster of hairs. Rarely, blistering occurs in the lesions. Permanently, bald patch may develop. Sometimes no follicular scaling or inflammation is present, but bald areas of scarring slowly appear, often looking razor-like footprints in the snows. This is known as pseudopelade. Sometimes no follicular scaling or inflammation is present, but bald areas of scaling slowly appear, often looking razor-like footprints in snow. This is known as pseudopelade. Other form, bullous lichen rubber planus. Israel. Blister appear within lichen planus papules or by themselves, generally on the lower legs. Actinic lichen planus. Only affect sun-exposed sites such as face, neck, and the back of the hands. Affect sun-exposed sites such as face, neck, and the backs of the hands. Lichen planus pigmentosa. In some patients, oval grayish brown marks appear on the face and neck or trunk and limbs without an inflammatory phase. Bullous lichen planus. Israel blister appear within lichen planus papules or by themselves, generally on the lower legs. Actinic lichen planus only affects sun-exposed sites such as face, neck, and the back of the hands. Lichen planus pigmentosa. In some patients, oval grayish-brown marks appear on the face and neck or trunk and limbs without an inflammatory phase. In all forms of lichen planus, we can see the Kubner symptom. In all forms of lichen planus, we can see the Kubner symptom. Differential diagnosis. Lichen rubber planus and psoriasis. Subjective feeling. Lichen planus, intense itching. Psoriasis, less intense itching. Predominant localization. Flexor surface, psoriasis, extensor surface, hairy part of head. Extensor surface, hairy part of the head. extensor surface. Higher part of head. Infection of mucosa in 30–40% of patient. Lichen ruberplanus. Psoriasis commonly not observed. Infection on knees commonly absent. Psoriasis in 40–60% of patient. Infection on joints. Lichen ruberplanus not observed. Psoriasis in 25–30% of patient. Form of papillus. Lichen ruberplanus polygonal, psoriasis round. Lichen ruberplanus polygonal, psoriasis round. Tendency towards fusion. Lichen ruberplanus less marked. Psoriasis marked. Additional sign. Lichen ruberplanus waxy shine, central groove, Wickham stria. Waxy shine, central groove, Wickham stria. Psoriasis, psoriatic phenomenon or positive psoriatic trait, Auschwitz. Значит, sign, subjective feeling, lichen ruberplanus, intense itching, psoriasis, lens itching. Predominant localization, lichen ruberplanus, flexor surface, psoriasis, extensor surface, higher part of head. Infection of mucus in 30–40% of patients, psoriasis commonly not observed. Infection of nail, lichen ruberplanus commonly absent. Psoriasis in 40–60% of patients. Form of papillus, lichen ruberplanus polygonal, psoriasis round. Tendency towards fusion, lichen ruberplanus less marked, psoriasis marked. An additional site, lichen ruberplanus waxy shine, central groove, Wickham stria, and psoriasis, psoriatic phenomenon. Как завершить показ слайда? Не знаешь? Вот тут?
Что?
Вот тут?
Я не знаю, просто говорю. Что было?
Завершить показ слайда. Максим, подойдете, да? Я уже как бы дальше. Угу. Вот здесь остановить запись. Вот тут.